And there was a very nice article which was looking at whether ARNI is going to decrease the device therapy. So we do know that device therapy is a class 1 indication according to the American College, a very strong recommendation. And we know that whether you have a ischemic etiology or a non-ischemic etiology, the recommendation for ICD is very, very strong. It is in patients who are symptomatic, it's in patients with the EF less than 35, and it's patients who you've given good 3 months of therapy and they have a good functional status, and those are the patients who get the devices. Now, if you have a patient who's on OMT, which would obviously also include ARNI, and if the patient is on ACE, you need to replace with ARNI. He's symptomatic and he has an EF less than 35, and you've had at least 3 months of OMT, ICD is the way to go. If you have a patient who is symptomatic with a wide QRS of 120 to 150, then a CRT-D is the way to go. If the patient has a fairly end-stage heart failure and on MRI, you don't have a significant scar, especially seen in the non-ischemic dilated cardiomyopathy patients, then a CRT-P is a good thing to give because it costs substantially less. So in patients, we know in CRTs, there are almost 1/3 of them are non-responders. So these are the patients we believe will actually benefit with ARNI use because the EFs will improve, adverse cardiac remodeling will be prevented, and VPCs come down and you have the biventricular pacing actually optimized.